Hey everyone, welcome back to our second and one of the probably I would consider most important post-operative presentations that we're going to do. And this is related to knee osteoarthritis and total knee arthroplasty, or TKA. And I just want to spend a little bit of time discussing articular cartilage. Just a little bit again. This is a review for those of you who have listened from the beginning. But what we need to think about when we think about patients who will need a total knee arthroscopy or a TKA is this idea that their cartilage is broken down. And that happens because cartilage, as we know, is avascular. So it does not have blood flow. It also does not have nerves. And it also lacks the lymphatic system. So it doesn't have the same inflammatory response that allows for things to heal the same way that other types of tissue in our body does. So it cannot regenerate. And that's the important thing, is that we need to recognize that when cartilage gets injured, it has a much harder time to heal. And we've talked about this several times. This is hopefully just a review for you guys. So let's talk specifically about the knee and the cartilage around the knee. So we have probably recognized, just being therapists and trainers and working with patients who have knee pain, maybe having knee pain ourselves, that the knee gets loaded from the top and the bottom. And as long as we have cartilage and things like a meniscus intact, those things are designed to actually take on the load from our body as well as the load from the ground. And so it distributes the weight evenly around the knee. So that's what this picture is showing us. What you'll see here, though, is this is actually just a very simple diagram to show you that when we lose something like the meniscus, and the same thing with our cartilage, we actually lose that ability to distribute force over the entire joint. And so a normal joint that has good meniscus, has good cartilage covering, then you'll notice that we have the load distributed throughout, which can then allow for the load to not damage any of our tissue. But once we lose that ability from the tissue to take on the load, then we start having the joint wearing down. And this picture here is providing you with some sort of demonstrations of cadavers, as well as possibly other tissue that might be having a surgical repair. It shows you how that cartilage can wear down, so we can have big holes. And if you were part of the last presentation about the ankle, you saw very similar things happening to the talus, where the cartilage actually starts to get holes in it, and we start to get tissue damage all the way down to the subchondral bone. So when we're thinking about this, we need to think about what leads to osteoarthritis. And we're going to talk about osteoarthritis throughout this entire section, throughout Module 1, because osteoarthritis is basically defined by this idea that too much stress happens to the joint, which leads to inflammation and likely cartilage damage. And so this type of stress can happen either because joint mechanics aren't good, joint mobility isn't good, maybe the patient is overweight, and maybe they've had some sort of injury that has led to movement changes. So as I'm hoping you guys are all aware, as therapists, our primary job is really to be able to look at movement, to be able to recognize when there are movement changes or movement problems so that we can help a patient change their movement pattern and improve their coordination so that they don't end up causing excessive physical stress on the joint, which can then lead to osteoarthritis. We tend to diagnose arthritis through MRIs and x-rays, but we also will hear similar stories from our patients. So as we've talked about through this program and through the classes that we've been giving, it's really important that you hear the story of the patient. And you're looking for certain things that they might tell you. One of the most common things is that they will demonstrate decreased range of motion, and possibly they will tell you about the history of a previous injury that they've had to their knee, to their ankle, to their hip. And then they will also report morning stiffness, oftentimes an hour or so. This is very common with patients who are coming in with some sort of hip osteoarthritis, and it's oftentimes what leads surgeons to recommend surgery, such as a total hip replacement. And it's the same thing with the knee. If that stiffness is lasting for more than an hour or so in the morning, then they likely will recommend that the patient has surgery. And then obviously, other things that we think about is age. As I'm sure you've heard before, hip and knee replacements only last for a certain amount of time. And so we really try as clinicians to provide conservative care of some kind for as long as we can before they actually get the replacement surgeries. So if they're under the age of 60, the doctors will recommend that they continue therapy without providing surgery so that they do not have to do multiple replacements of that joint. So as we're considering these patients and the possibility of non-operative care, we need to think about what we're trying to do. What is our primary focus for these patients? So again, we can try to avoid having to need a knee replacement, hip replacement. Again, these are very, very similar in terms of our goals and the patient's goals for therapy. And so we want to try to make sure that the patients are moving correctly. And this is a big part of some of the other classes that we teach. We're hoping that we can do some in-person labs where we can talk about and provide examples of ways that we can work with your patients and show how a proper movement mechanics are supposed to look. We also, as therapists, are going to improve joint mobility, so encouraging motion. Oftentimes we see with these patients decreased knee extension and decreased ability to perform knee extension because of strength issues. And so we're going to improve strength and coordination as well as providing mobilization to increase knee extension. And then another big thing is maintaining ideal body weight. So oftentimes what we found, and this is probably a much bigger problem, honestly, in the United States than it is in China, but this weight-bearing stress becomes a problem as people age and gain weight. And so if we're working with patients who are overweight, we're going to talk about how important it is to provide patient education for decreasing weight. But we also want to provide them with ideas for how they can perform exercise and activity without causing stress to the knee joint. And so ways that we can do that would include things like exercise in the pool. This is a very big opportunity that therapists have in the United States. And I think it's starting to become something that people are talking about here in China. This idea of actually providing aquatic therapy so that patients can continue movement, continue mobility, can actually increase cardiovascular health in the pool where they're not getting a lot of pressure on their knee joints. And so that helps them hopefully start to lose weight, as well as providing them with the ability to move and improve mobility. Other options are things like cycling. So sometimes patients will be very happy with a stationary bike or providing, cycling around the city. Also things like cross-country skiing. There are shock-absorbing treadmills, things like an Ultra G, where you can take weight off of the body if they're quite overweight. And then also walking on softer surfaces, some tracks are designed to allow for that. So any of those things where they're not having as much weight put through their knee and not having as much pressure on the cartilage can help decrease pain and allow patients to continue to exercise. And so we, of course, have to recognize that encouraging motion and doing so with the right joint mechanics is very important. So we're not going to go into detail about this, but any of you who have worked with me with the lower extremity, the classes that we did, you're going to know that this is what we spend our entire week on, is mechanics and making sure that we have good control of the hip and the ankle foot, because if we don't, then that can actually lead to more problems at the knee. And so the knee is really controlled by the joint above and below. And so we're going to spend a lot of time watching movement patterns and trying to improve joint mechanics, and at the same time encouraging motion. And so sometimes we need to do joint mobilization, as I talked about earlier, to allow for full knee extension as well as good knee flexion, and possibly improving the mobility of the patella. So there are some different programs out there. In the United States, there's a program called Twinges and the Hinges, and it's a water aerobics class that they actually do through the Arthritis Foundation. And so these kinds of things help these people who have some pain, who are trying to help avoid surgery or postpone surgery, be able to get out there and exercise. And so just being aware of any possible programs in your community and being able to encourage that for your patients, I think is a big deal and kind of a great option for them. So of course, non-operatively and post-operatively, we want you guys to be doing evaluations on your patients. And those evaluations should include some sort of manual muscle testing. And again, we're hoping that you're initially assessing big functional movements like squats and walking and stairs, so that you can figure out from those big functional movements if they possibly have hip extension weakness, hip abduction weakness. Maybe they're not providing you with knee extension during gait. Maybe they're not providing good push-off during gait, terminal stance. And so we want you to then test for strength of those particular muscle groups. And when you look at those things, of course, recognize that those things are likely leading to increased knee osteoarthritis, knee pain. And so therefore you will treat those things with non-operative and possibly post-operative treatment. Other things we have to recognize is that movement patterns also change when people have decreased balance, decreased proprioception. And so sometimes there will be injuries in their past. Some of our patients may have had falls. Some of our patients may have had some sort of injury that is leading to decreased balance, or a history of something that leads to decreased balance. And so this, of course, is another big piece of our non-operative and post-operative treatments. So we need to be doing assessments for balance as well as treating for balance. And then the other big thing that I alluded to earlier is maintaining an ideal body weight. So there's been plenty of research to show that hip, knee, and ankle joints are all affected by body weight. As what you can see here is that each kilogram of weight adds 4 kilograms of stress to our knees, and basically 6 times as much weight to our hips. So our hips actually get more of those that pressure, but our knees get a lot of that pressure as well. And so you as a physical therapist, you're not necessarily the person who can provide a lot of nutrition education, but you do want to talk about things like blood sugar, patients finding out their past medical history, and if the patient has something like diabetes, this can cause inflammation, which leads to tissue damage, especially cartilage loss. And so, again, educating your patients on ways to control their diabetes, hopefully through diet, but also through medication, can help to decrease that inflammation and help to improve their cartilage tissue and their cartilage health. And so, again, if we're trying to go non-operatively, then we really want to make sure that they're eating well, that they are keeping their diabetes in control. And we also want them to stay physically active. So we don't have time in this class to go through all of the research related to activity and osteoarthritis, but what we can say is that the best preventative measure for developing arthritis, as well as being able to decrease the likelihood of surgery required for somebody who already has osteoarthritis of the knee, is physical activity. And so continuing to stay mobile and performing physical therapy activities really does help to decrease the possibility of needing surgery. So with that being said, we can talk a little bit about when surgery is appropriate. Oftentimes in the United States, surgery is not going to be done until we have exhausted all of the conservative therapy. And so that would include physical therapy for greater than 6 months. But patients oftentimes will also have steroid injections, medications, anti-inflammatory medications. They might work with a trainer for a period of time. And again, those types of things are done for an extensive period of time, usually years, before we just consider surgery. Patients that also obviously have severe pain with weight bearing, and then on imaging, we're able to see that there is significant destruction or decreased ability for the articular cartilage of the knee to actually provide shock absorption. Those are going to be patients that will oftentimes get surgery, as well as any type of severe deformity that would show varus or valgus. So again, where the knee is showing significant amounts of pressure on either the inside or the outside of the knee. In those kind of situations, then they're oftentimes considering performing either a partial knee replacement or a full knee replacement. So the technique has been very, very well researched, as well as very well performed, and doctors that have been doing these for years. They're very, very good at knee replacements. I'm very confident with the surgeons in China. I was very confident with the surgeons in the US when it comes to doing this surgery. Basically what they do is they provide an incision from the middle part of the thigh to the proximal tibia. So it is a pretty large incision. They basically move all the muscles to the side, and then they remove the distal part of the femur and the proximal part of the tibia, and they replace both of those with some sort of component. Sometimes the back of the patella also needs to be resurfaced, and so they will go in and resurface it and replace it. So there's a video that provides you with great education about what that looks like. I'm not going to provide you with that video now because I want you guys to be able to get a translated version of that video. So that's probably just going to be part of the group of videos that you will be provided. We might actually try to put it into this particular video, but again, it might also just be separate. We want you to have a translated version, so I prefer that it was done that way. So we'll see. But we're hoping that you recognize some of the adjunct videos that we include with these classes, and definitely being aware of what the surgery looks like and being able to see a video for it, I think, is important. So with that being said, I want to finish up with some of the things you need to think about related to complications from this surgery, because complications do occur. We see these surgeries so many times. I have seen at least 1,000 patients in my career that have had total knee replacements. And very rarely do I see complications, but they are out there. Probably the biggest complication that you're going to see is a DVT, or a deep vein thrombosis. And you'll see a picture here of what that looks like. And basically what happens is that we end up with decreased blood flow in an artery, a vein in this case. And the vein then has that blood flow that builds up in one area. And then it can lead to a clot, and that clot can then lead to other complications. And so you'll see here we have what's called the Wells DVT prediction rule. And I'll reference this later so you'll be able to see where these things come from. But if you're seeing these patients regularly, you definitely want to be aware of symptoms that might be leading to DVTs. This is something that I would say in the outpatient or home health setting is something that you need to be aware of more than if the patient's in a hospital setting. We're hoping that if they're in a rehab hospital or some sort of inpatient setting, that this is something that nurses and doctors are aware of. But you as a therapist still need to be aware of what the DVT could look like. And basically the way this works is you're giving extra points for things that would possibly lead you to think of a DVT. So you'll see here, patients, if they have some sort of active cancer going on, they get a point for that just off the bat because of the amount of other complications that can happen with cancer. We need to think that DVTs are possible. Also, if they've been bedridden for more than 3 days, or have had other big major surgeries. And so this is a lot of our patients, unfortunately. As we've talked about already, in China, people tend to be completely bedridden for entirely too long. And so if that's true, then we need to consider the fact that the DVT is much more possible if they haven't had any movement of any kind for more than 3 days. Also things like a paralysis or some sort of plaster mobilization, meaning a cast of the lower extremity. If their calf swelling, if you were to measure the circumference of the calf, is greater than 3 centimeters compared to their good side, that's another possibility of a DVT. If their entire leg is swollen, so not just the area around the surgical site, not just the area around the knee, but the area way above the knee and way below the knee. And so below the knee is much more common. As we know, anytime we have lower extremity surgery, swelling is normal. But if you're knowing significant swelling above and below the knee, you'll see that also gets a point. Localized tenderness along the deep venous system. So if you can follow veins, and again, I don't expect you to know exactly where the anatomy is of all of the veins in the lower extremity, but if you can follow a specific line, maybe down the leg where there's significant tenderness, I would possibly consider the possibility of a DVT. Any type of significant pitting edema, and we won't go into detail about what that is, but basically if you press hard, let's say on the skin above or below the knee, and that skin doesn't bounce back pretty quickly, that could be a DVT. Any previous history of DVTs, and any significant superficial veins that you can actually see through the skin. Those are all things that we think about the possibility of a DVT. You just want to keep track of it. Again, if you're in an inpatient system, talk to the doctor about it. If you're an outpatient, watch it and make sure you have somebody you can contact with the possibility of reporting that DVT. Other complications that you might get, infection. I've honestly seen infection more than anything else, and I probably have seen infection about 5 to 7% of the time with these patients. So keeping track of what the surgical site looks like, making sure that there isn't a lot of heat or swelling directly around the surgical site. So again, it's totally normal to have edema, and edema all the way up down the leg, especially from the knee. But to have redness and swelling right around the surgical site is not normal, especially several weeks after the surgery. So keep in mind that that could be true. Loose hardware doesn't happen very often. In China, it doesn't happen. In the US, it doesn't happen. But there can be situations with malalignment. So most of the time, the doctors are really going to try to make sure that the surgery where they're trying to replace the distal femur as well as the proximal tibia, that alignment is really good. If the patients have leg length discrepancies, sometimes they'll actually do a surgery to improve on that discrepancy, because that discrepancy might have been why they had the surgery to begin with. So they're hopefully going to decrease the likelihood of malalignment, but unfortunately it does happen sometimes, especially if the surgery wasn't done quite correctly. So just keep in mind that those things could be complications that you see. So that's kind of where I want to end this particular presentation. When you look at these DVT prediction rules, keep in mind that a score of greater than 3 is considered high risk, and a score of 1 to 2 points is considered moderate risk. If they basically have 1 or less, like 0 points, then they probably don't have a DVT. So I just want to make sure you understand the numbers there. Again, greater than 3, definitely consider that high risk. The next group of slides that I'm going to present in the next presentation will actually go through the rehabilitation for a total knee replacement and talk about outcomes. It's really important that we recognize what outcomes are supposed to look like and how we can improve on outcomes for total knee replacements, because again, as I said at the very beginning of this presentation, total knee replacements are the thing you're probably going to see the most. I definitely saw them more than any other surgery in the United States. They tend to be a little bit less frequent in China, but they're still pretty regular. And you need to be comfortable with not only the surgery, but obviously what you should understand your outcomes should look like for rehabilitation. So that's where we're going to start off with the next presentation. Okay,